I'm Sarah Munoz. This is Josie Ibarra, and this is Charlene Stillion. We went to the annual diabetes conference up in Jackson this year, so we are here to share some of our information from that seminar.
There are some handouts. The three biggest ones are a list of all the medications that are available for type 1 and type 2 diabetes. The other two handouts are what those cost, which is very scary.
I love that you did that.
Very, very scary. And we did a little bit of research. This morning I did a little bit of research. Basically, just in the last 4 or 5 years, the cost of diabetes medication has gone up almost 41%. And you'll see on these slides, we had 2 endocrinologists there that were so totally awesome. You can't even believe these people are in our state and are servicing our people, because they are so unbelievably just brilliant people. And Dr. Miller was especially passionate about the cost of medications, especially insulin, because she is a type 1 diabetic. And you'll see through these slides, diabetes medication has gone from costing pennies to costing a fortune. And there's actually no reason for it, other than the pharmaceutical companies are making a fortune. Rachel actually sent out a petition in order to help, just a petition drive to get the cost of diabetes medication decreased. If you run across this petition, please sign it. I do not sign petitions, I signed this one. Because it's just, when you look at the cost of medications, it's just unbelievable. This one we will be going over, so in case you're just going to think you're going to sit there like a lump, this is interactive, we are doing some of that. So, and I am not computer savvy, and we all know that, so bear with me. Okay, so, the latest thing they have in pumps, this will, in the next 2 years, they are actually coming up with what will amount to being a true artificial pancreas. Not something that's implanted inside your body, but something that attaches to your body. They have continuous glucose monitoring, which is on here, you'll see that as CGM. That monitor will be talking to your insulin pump and adjusting your insulin accordingly. This is, Medtronic is the one that they're making the most strides. They are the ones that are, they're making the most strides in the artificial insulin, artificial pancreas. The thing that's weird though is that the insulin pump, you have to change the probe every 3 days. The CGM you change every 7 days. So they're trying to get that to made up. That's the biggest problem you have. So, this is the reasons why you want to do insulin pumps. They're more like your pancreas. They give better glucose control if you have to have insulin.
Something that I wasn't aware of that I really took from this conference was they talked a lot about the hypoglycemia and how bad it was at night, the nocturnal hypoglycememia, and how a lot of these patients will slip into that, but they won't actually even know that they're slipping into it. Even if their machine's alarm, they sleep through it. Yeah, they sleep through it basically, or they're so far out of it with the hypoglycemia that they can't awaken to realize that they're that hypoglycemic.
And yeah, the other fun thing is when you get into hypoglycemia, then you also get into heart arrhythmias and you die. So they can program these pumps to stop delivering insulin in the early morning hours, which that seems to be when they have the dawn. What they're talking about is the dawn phenomenon. I learned it as the Smoji effect. Yeah. Old term. So that was news to me, is that a lot of people who have diabetes die of heart attacks in the middle of the night. So if you have somebody they died peacefully in their sleep and they're diabetic, chances are this is what happened to them.
Is that called track of their glucose, so they know that they're monitoring all their
Mm-hmm. Yeah, and it's pretty fascinating. I mean, they can upload all of this data onto their computers when they go for their doctor's appointments, and they can see actual trends of where the blood sugars are falling at different times. I mean, even if they're checking their blood sugars and they look like they're in a great range, but then their A1C is completely out of whack, they can go through and they can see these individualized graphs and say, okay, this is where you're spiking, but they weren't picking it up because they weren't testing it those times. So, it's pretty fascinating.
And all of these pumps can be run by your iPhone. There are apps, and you can't upgrade your app except at the doctor's office. The doctor's office, your diabetes educators get the upgrades, and they can upgrade they only have it for iOS, they don't have it in Android yet, but they're planning on that because, most of us have Samsungs. Not to be a snob, but, and of course, if you have your A1C, you don't end up with the other problems that go on with diabetes, the heart problems, that kind of thing. This is the CGM. So basically, you have a CGM. It passes everything to your receiver. The insulin pump turns on, and it's done. So this is not that long in the future. This is around the corner technology. This isn't space age. Oh, in 20 years we're going to have this. This is this decade. We will have this. So the problem with half the people who are on insulin are type 2 diabetics. So eventually, if you live long enough, you're going to be on insulin. So that's why there are two sets of information there. Because nobody's only on just one medication. Most people start out on metformin, but it's added to. The cost of this is astronomical if you don't have insurance. Type 2 is like $400, that kind of thing. So, of course, the easiest thing is to take a pill. And so this is, when you look through this stuff here, let's see, which one? This one. This one here will tell you what the different medications are, how they work. We're not going to go over that today because lots of information. It also gives you the fun name for them and the generic name for them. So this one will kind of give you an overview of how each medication works, how it works on the body, because some of it works in the intestines, some of it works in the pancreas, some of it works on the liver. Everything, and sometimes you need a combination of drugs. Anymore, the combination drugs are becoming more popular. Glyburide is rapidly becoming out of popularity because of its heart-damaging effects. And since most of our diabetics also have heart disease, you aren't going to see a whole lot of glyburide or glipizide in the future. So monotherapy, obviously that means one. Metformin's the most popular. The rest of them, not so much. It's also the cheapest. If you don't have insurance, metformin is $10 a pill for a 1,000 milligram pill. So obviously, if you have insurance, it's cheaper. Anything else down here is the newer it is, the more expensive it is. And once again, these increase. Some of them just get rid of. They get more. Instead of having the glucose recirculate, that kind of thing, it goes out in your urine instead of recirculating in your body. The newer ones are more heart protective. This was very interesting. I think the lady that was from Jackson, Dr. Miller, her whole thing was they sold the patent for insulin back in the 1940s for a penny, and still made a fortune. But that was back then. That's porcine. That was all pork based, and since then, insulin has gone up dramatically. So we'll get to that later. So depending on what kind of diabetes you have as to what you get. If your A1C isn't under control, eventually you will end up on insulin. It kind of goes like this. So eventually you will end up on insulin if you don't keep your A1C. That's the takeaway to keep your insulin under control, your A1C under control, diet, exercise, and that kind of thing. So to that point, get out your little doohickey. This is our interactive portion. So there's 2 pages to this. I thought this was helpful for those of us who aren't diabetics also, because it has at the bottom, you'll say increase, decrease, take or do, and control or check with your provider. So on fruits, increase, decrease, if you're diabetic. What do you think? Or is this the great unknown? It depends. So this is going to decide it. If you eat a lot of fruit, your diabetes is going to be out of control too. So, how about saturated fat? Decrease. Unsaturated fat? Increase. Alcoholic drinks?
Is there ever a list where that's an increase? Oh, yeah.
Spring break. Whole grains. Okay. Dietary fat. Yeah, you're going to control that one. Baby aspirin.
Depends.
Yeah, that one's a check with your provider before you just start with that. Your medications.
Take with your provider.
Okay, so most of the medications are expensive, but there is help. But anyway, low-fat dairy.
Guessing that will increase that.
All right. Exercise.
Increase.
Smoking.
Again, when would we ever?
Oh, I ran across a study that was done in Europe. And because of smoking, you have decreased population, so they don't get old enough to cause strain on the healthcare system. B1 positive to smoking. Hope, belief, love, laugh, and relax. We all increase that. Omega-3 fats, seafoods, and that kind of thing. Okay. Provider visits. Yeah, actually do them.
Or do those?
Caffeine. I had trouble with this one. Can't. Excess weight. Okay. Stress. Because we're all good at decreasing stress. Salt. Okay, and if you are diabetic, visit your diabetes educator. Okay. So there's another page. Some of them are duplicated on there, but you get the idea. Just kind of, but this would be good if you know somebody's diabetic. This kind of is a control thing. This is what I can do to control my diabetes.
And I like that Marianne Horowitz is the one that actually put that together, and the way that she described it is you can actually sit down with the patients and you can pick what interventions they want to work on at that point. So it targets the individual, it gives them a little more of a sense of control over what they're doing and what they're going to be able to do.
And towards that end,
Already?
we're going to find yours.
I got it.
Okay. And then we'll go more into the costs of stuff. You got it. By all means.
So my presentation is really short, so you don't have to keep up with this accent for too long. No. It's better if I joke about it than anybody else. So this presentation is based on Marianne. She was a presenter in Jackson. she's a registered dietitian. She put a ton of those little letters. And I try to keep up with those. But of course, there's no way I can keep up with that. So she covered information that everything is research-based. So I know nutrition is so simple, but there's a reason why we say eat walnuts. So we're basing it on research. So I really enjoy her presentation because everything is based on research and the latest one. So it's really interesting to know that what I was saying is like not longer current. So it was good to go. Basically, my objective today, or her objective, was to explain the latest nutrition intervention recommendations to normalize outcomes such as the A1C, blood pressure, and blood lipids. So she found this acronym, a diabetes meal plan, and she based her presentation based on this acronym. It's pretty crazy because I don't really think it goes with it. I hope she doesn't watch this presentation. She was amazing, but you'll find that out. Most of my A's are avoid, or most of my I's are intervention, or something that doesn't really go well with an acronym. But anyway, so I have 17 points to cover with you today. And I'm basically touching on the point, the recommendation. Not really explaining every single one of them. I could, if I know the answer. But I have the PDF file with me where you can find more information in each point. And then you'll see also with this PDF file, you see what research she based it on. So the first one is avoid sugar sweetened beverages. See, nutrition is really simple. So you know what I'm talking about. You know it's sugary drinks, pop, all of that stuff. And the recommendation is less than 10% of your daily calories. So I'm going to be saying this percentage throughout the presentation a ton, and I want you to have an idea on how dietitians make those calorie recommendations. So simple. If you're within a normal BMI, which would be 18.5 to 24.9, that's the normal BMI, then we just multiply your weight in kilograms times 25, or 25 to 30. So if let's say I'm 40 kilograms, I'm not. Then I time it 25, and then it will give you how much calories you need a day. Okay, so that way you guys have an idea on how much you are supposed to limit your sugary drinks. Am I making sense with this? Perfect. So the next one is divide daily calories into more or equal to 3 moderate meals, or more or equal to 4 smaller meals. Most of the population I see, the diabetics that I see, they're eating 1 big meal a day after work. So a recommendation, and this is going to come up again in another letter, which is the same message. Have them eat throughout the day. 3 moderate meals or 4 small meals. So there's a lot of people coming to me, it's like, I have to take my cinnamon pill. I think we covered this before. And I saw it in a magazine that cinnamon will help control your blood glucose. Well, it isn't. There's no research backing it up. So same thing for this other ones. Chromium, cinnamon, herbs, vitamin D. None of them are clearly demonstrated. So I think that's good for probably all of us to know. So patients are telling us that, oh, I'm taking all of the supplementations, and it's like, nah, stop taking that. And that's good for me because there's over 1 million of those supplements, so I don't want to really get into each of them. The next one, increase plant stanols and sterols to 1.6 to 3 grams per day. So stanols and sterols, cholesterol, so they're substances that chemically look like cholesterol. So when we eat those, our body is kind of being full. Because it's like, oh, it's giving me cholesterol, so the arteries is kind of like using those sterols and stanols, but they get really digested. so they don't get stuck in our arteries. So this is why we're recommending this stannose and sterols to be 1.6 to 3 grams a day. Am I making sense? Where can you find them? Over-the-counter margarines or any spreads. They're adding those to those over-the-counter foods. Yogurt, cereals, orange juice. They might carry some of this sterols or stannose. The next one, assess the need for weight loss for overweight and obese patients with diabetes. So it's shown that if people loses weight, 5% of their current body weight, it will help them control their blood glucose. Optimal is 7%, if they can lose 7% of their body weight. But it only works with people with insulin resistance, which would be diabetes type 2. It doesn't show, there's no much research backing it up for insulin deficiency, which would be type 1. Or we have those type 2 that progress to insulin deficiency. So we can ask type 2s to lose weight, but really we cannot ask type 1 to lose weight based on research. The next one is boost viscose soluble fiber to 7 to 13 grams per day. So I added the viscose part of it because she said it that way, but I had to practice that word for it. I'm like, I can say viscosity, viscous, so I'm hoping I'm saying this right. So this is basically the difference between insoluble fiber and soluble fiber. Easy. Something that dissolves or something that doesn't dissolve. So we want the stuff that dissolves. So quick thinking when I talk to my patients is like, think of oatmeal. So it has a lot of soluble fiber, and you can see it's becoming sticky. But if you have the fiber from celery, put it in water for 3 days, and it's still going to be that fibrosity in there. So that's the main difference. So what has the most viscose soluble fiber out there is the psyllium seeds will give you 5 grams of that soluble fiber. And remember, we want to get to 7 to 13 grams a day. A pear is only really giving us 2 grams. An apple is 1 gram. So it's hard to find. So this is okay to have a supplement in there. The next one is ensure that patients with diabetes on insulin carb ratios subtract 50% of dietary fiber that is greater than 5 grams on label. The same thing to be done with sugar alcohols. Before I go through my next slide, which is going to show an example of this, I want you to remember that this education only goes for type 1, not type 2 diabetes patients. Because otherwise you're going to have all of those that type 2 diabetic patients. Oh, really? So they start adding all this fiber so they can keep adding carbs because they know they can subtract. So it doesn't work for diabetes 2. It's only type 1. Okay? So this is what they're talking about. If you see a label, it's really hard to find a label with greater than 5 grams of dietary fiber. So, but if you do, 50% of this would be 2.5. Ooh, I'm a genius. 2.5, right? So then this, you can subtract from this. 20 point something, right? Well, then you know what I'm doing. Same thing with sugar alcohols. If it's over than 5 grams, then you half it, and then you can subtract from total carbohydrates. Is that making sense? Easy only for type 1. Don't even bring it up to type 2, because they're going to start doing it, and that's not appropriate. Treat high blood pressure in patients with diabetes. You know how to do this better than I do. But what I do with blood pressure greater than or equal to 120 and 80, life interventions. Stop smoking, limit alcohol, lose excess weight, exercise regularly, and recommending the DASH diet, which recommends low sodium, high potassium, high calcium, high magnesium. So we can really have a whole class about DASH, but it's a good diet to recommend for blood pressure. The next one, ensure carbohydrate amount per meal and snack individualized to meet blood glucose target. So this was kind of said in the first slide, and it keeps coming back, because carbohydrates and all carbohydrate beverages are important to be measured for every person to control blood glucose. The next one is shrink saturated fat to less than 5 to 6% of your calories a day, and replace it with monounsaturated fatty acids, which would be omega-7 and omega-9. So now in this presentation, she talks a lot about monounsaturated fatty acids and polyunsaturated fatty acids. So mono, it's omega-7 and omega-9s. And usually the mono is hard at room temperature, but when you eat it, it turns to liquid. Poly, it's the omega-3s and omega-6. So that's kind of like the best. Those are walnuts. So omega-3 and omega-6. So omega-3s and omega-6, they're liquid in outside form, and inside form, still liquid. So they're oils. Peanut oil, peanuts, it has to be the oil already when you buy it and when you consume it. I hope that makes sense. Okay, now this is not working.
Oh, there it is.
Okay, so then easy, this has been going on forever. Make at least half of your grains whole grains. We all know that. The next one, ensure intake of antioxidants, rich fruits, nuts, veggies, whole grains, not from supplementations. We have a lot of patients coming with, taking antioxidants through pills. So that's not recommended. So through food. The next one, assure consistency, timing, and even spacing of meals on carbohydrate intake. How many times had I say this? She mentioned it forever and ever and ever. So this is important, okay? The next one, learn the fructose consumed as free fructose. Blown away. This was new to me because fruit, I was like, limit your fruit because it's still sugar, it still raises your blood glucose. So there's new research saying the fructose is better absorbed and results in better glycemic control than any of those isocaloric intake, which is sucrose and starch. Isocaloric means that it will give you the same amount of calories. So a piece of bread will give you 80 calories, and maybe if you have a big apple, will give you 80 calories too, but it's better absorbed in the body. So it's less impact on your glycemic control. So now we're good to say eat as much fruit as you want, which is amazing. So that's a new thing, and that's why I was like, I think I have something to share. There's new things, So fructose not likely to have detrimental effects on triglycerides as long as intake not excessive 12% of your intake. So now because they're also worried about the triglycerides, so less than 12%. The next one, provide lean protein for health, 15 to 19% of your calorie intake, or 0.8 grams per kilogram without renal comorbidities, because the game changes when there's comorbidities, right, for everything. So protein doesn't significantly show absorption of carb food. So do you guys remember recommending like peanut butter on crackers? So you have your protein and your starch, and that way the blood glucose will stay leveled. Well, not anymore. So now they say protein has nothing to do with how much your blood glucose is getting impacted. Blown away too. I was like, no! I don't want to see my previous patients where I was already like it. I was like, no, I'm not dietitian for that patient. Like, Rachel, you can go over this. But I was like, I want to find a way why. But it's the way I'm backing myself up with those patients is like protein, it's digested differently. So protein takes longer to digest. And I'm going to tell them that. Keep eating your protein because you want to feel fuller longer. Because if you don't feel fuller longer, you're going to go back to that starch and your blood glucose is going to get impacted. Do you see the difference here? I still do recommend protein, but not to prevent that glucose to go up, just to keep them fuller. So that's a new thing.
I remember they said especially your nighttime snack right before you go to bed doesn't necessarily have to be the standard peanut butter and cracker thing. You can have pretty much whatever you want. And that was kind of like, what? This is what I've been taught in school, this is what I've lived by. It was very mind-blowing. I love what she said.
So Rachel and I were like, no, she's crazy. I mean, she didn't go to school. Like, where's she at? But she's backing everything up. She put it together really neatly. Like, she put a logo of like the Academy of Nutrition of Dietetics, the American Diabetes Association. So she put all the logos, right? And then for every sentence that she was covering, she will put the logo, like where it came from. So I'm like, okay, I believe her. So it's pretty amazing that things are changing. I know it's nutrition. I know most people think like whatever, but I'm passionate about nutrition, and it's great to know these things, you know. So I thought I could share that with you. So lower total fat to 20 to 30% of calories. Let fat quality be more important than quantity. So because they're focusing on the mono and the poly, so that's quality. So it's okay to say you can have this fat, but fat is always going to be fat. Fat is always going to have 9 calories per gram. Starch is always going to have 4 calories per gram. So it's going to make you fat. So you have to know that. You have to know that you're getting more calories in through fat. So you're watching your weight. I'm not saying that it's really healthy to have healthy fat, because fat is fat, but it's healthy. I mean, it's not going to stay stuck in your arteries. It's going to help with lower LDL, increase LDL, lower HDL, all of those things. Yeah, well, that came out like, I don't know, 5 years ago or something, encouraging people to have omega-3s and omega-3s, marine or plant-based plant. So now you guys will hear us say, eat fish 3 times a day. Hopefully this kind of fish. 3 times a week. Not a day. So, okay, thank you. Allow patients with diabetes to consume non-nutritive sweeteners. I hate sweeteners. I'd rather not have that. But that's not the recommendation video, okay? So it's okay to allow patients to do this. It's proven that it can decrease the calorie and carbohydrate intake when substituted with sweeteners. I'd rather not have it than have it, but I guess for diabetes, it's better to just be okay with it.
I guess I have a question on that, if you don't mind, Josie. So I thought a couple of years ago they came out with, and I don't know who the they is when I say they, but I remember hearing about a study that showed that people who consumed diet soda actually consumed more calories than people who consumed regular soda. So I would have thought this would have been the other way around.
Thought about,
yeah.
Well,
yeah.
the thing with diet soda is that it tends to expand your stomach, and you get hungrier faster.
Okay.
As far as glucose control,
Right, as far as
the
that
artificial
goes.
sweeteners are the best
Right.
for diabetics. As far as the rest of the world is concerned, that's the problem with consuming artificial sweetened pop, is that it also bloats you, and then you tend to eat quite a bit more. And that's where that study came from. It's once again, you have to pay attention to what you're doing.
Yeah. Well, and I guess I would have assumed that would have applied to diabetics, because if we're trying to watch their weight as a type 2,
Right.
if we're talking about type 2s,
Yeah.
then I would have assumed that would have been logic from one to the next, but maybe the study hasn't been studied in diabetics, for example.
I know, I don't feel like doing this anyways, like, just, like, it's like, to me, I don't know, I'm not backing it up with research. Maybe I am, but like the taste buds adjust. So when we were babies, we were able to have that like broccoli, and we were like, because it's got sodium, it's got sugars. So we've learned to use more and more and more. So when I talk to my patients, it's like, you can cut it back in salt and sugar. So with this is just making, like, that's a chemical that you probably already know that's just exponentially sweeter, and you have to use just tiny bit, but it's still a sugar. So I just like to try to cut it back, be natural, just try to do that. But I'm going against research, but like, you know, it's just like, I just want to be more healthy and like getting them to be used to more of the natural being, not all the salt and sugar that we have now. But this is what the research says, so yeah, blown away too, I don't like it. So, nibble on nuts.
natural.
Nibble on nuts, 5 ounces per week, 1 ounce a day. So I said that right. Especially walnuts, pecans, almonds, and pistachios, best to isocalorically incorporate daily consumption for weight control. That's all my presentation.
The other thing on hers is, you notice there wasn't any mention of coconut oil on there.
Oh, I was gonna
Oh,
ask
yeah,
about that.
Nothing about coconut oil. She was anti-coconut oil, like you cannot believe it.
Coconut oil, it's a saturated fat.
And she was like, there's all this stuff about, you know, it's great for weight loss, it's great for everything. She said, there is no research that supports it.
There's no way to convert
Absolutely none.
coconut oil to be a mono or a unsaturated fat. It could be what it could be for marketing, but it's saturated fat. So we had a ton of Jackson people come over. And I don't mean to hurt anybody from Jackson. I mean, I'm actually pretty respectful from them. Like, they're really healthy and stuff, but it was like, what?
Oh,
And
yeah.
I'm like, dude, it's
There's a lot of-
saturated. Like, there's
lot of
nothing you
jaw-dropping
can do about
that weekend.
saturation. So it's saturated meat, like all of your meats are saturated, so it's just like it. Your body doesn't know if coconut looks pretty. You know, like, literally, that's the way I took it. I'm like, yeah, I mean, just take it.
Yeah, put it on your skin, put it in your hair,
Right.
don't drink it, don't eat it, don't fry in it, don't do anything with it. I mean, she was adamant about it. And since we're running out of time, the one thing I wanted to run past everybody was this one guy, the Dr. Repas from Casper. This guy has so many credentials, it's freaky. He's an epidemiologist, he's an endocrinologist, he's a lipidemiologist. His big recommendation, and this one I think blew away everybody in the room, was if you have a patient, and I'm not saying you tell everybody this because they have to run it past their doctor, but if you have a patient that is having trouble taking statins, all the statins, he said if you take 1 pill a week, you will be effective at reducing your cholesterol. It's not the optimal, but he said they have such a long half-life, and if you look up the half-lives of all those statins, it's a very long half-life. So if your diabetic patient who is trying to pump sludge through their blood vessels has just, if they can't take it because of muscle aches or they don't feel good or whatever reason, if they take 1 pill a week, it works.
I'll back that up.
I have told this to a number of people. They have gone to several doctors in town who reluctantly agree that this is true. And I mean very reluctantly agree that this is true and it is just as effective. And I don't think anybody in that room did not come away with, holy crap, really? Because that's the biggest problem with statins is you have muscle aches and you don't feel good. And this just, it was just like, to me, that was probably worth it for the whole 2 days for me. It was just learning that. So, we're kind of out of time, so thanks for everybody coming. I have some.
Wait, I want to read something.
Okay.
She's pretty goofy. I really like her. But she had a whole poem about diabetes, right? So it's included in her PDF file. But she meant, this is what I tell my patients, and I know they're probably thinking, like, really? It's because you are not diabetic. But I like it because it says, in many ways, diabetes can be a gift, as its lifestyle interventions will surely make you fit, so live, laugh, love, and believe, and years of good health you will receive. So all of the recommendations that we give them, like exercise, like take care of what you're eating, everything, I think, like, dude, like, you're good doing these things. So I thought, like, she was really goofy. I mean, this thing lasts like 3 pages, like the whole poem. But that part, I tell my patients, and I talk to the whole families, like, all of you should be on the same page. All of you should be eating vegetables. All of you, you know, like, that's, it was pretty cool to see that. Don't see diabetics like, oh, dude, can you, it's better
I try to be like him. So, thank you.
We also had a hippy dippy chick who's really into stress relief with meditation, and she was interesting. But she brought up a lot of good points, that a lot of the problems you have with diabetes and in general high blood pressure, most of us are in very stressful positions in life, and meditation, taking time for yourself, that was her message through all the crap. That's the biggest thing, is our lives are so spread out that this is why we were seeing so many more health problems with heart problems. We're seeing an increase in diabetes. We're seeing an increase in all kinds of chronic diseases because we are so stressed out. So.
Thank you.
Thank you.